You're listening to The Scoop on Ultrasound, where the world of ultrasound imaging comes alive through dynamic conversations. This episode is brought to you by EDM Medical Solutions. Season 2 of The Scoop on Ultrasound brought together voices from across the imaging world, pioneers, educators, innovators, each offering fresh perspectives on where ultrasound is headed. From the promise of AI to the power of advocacy and the lessons learned over decades of clinical experience, this season was packed with insight. In today's episode, we're looking back at some of our favorite moments, highlights that are helping shape the future of ultrasound and redefining what's possible in the field. And if you haven't already, make sure to follow The Scoop on Ultrasound on your favorite podcast platform so you don't miss what's coming next.
Quality supplies make a difference. At EDM, our mission is to help you enhance patient care. For over 30 years, we have been a leading supplier of medical imaging products and accessories. It all started with one product, Crystal Ultrasound Gel. And now our catalog includes over 300 products designed to support your practice. From probe covers to needle guides, EDM Medical Solutions is the partner of choice for over 2,000 healthcare facilities in the U.S. Learn about our range of ultrasound solutions on our website by visiting us.edm-imaging.com.
Let's start with episode 3, where we heard from Dr. Michael Blaivas, Chief Medical Officer at ThinkSono and a pioneer in point-of-care ultrasound. In this conversation, Dr. Blaivas explained how ThinkSono's AI-guided software is opening new possibilities, allowing non-ultrasound specialists, like nurses, to perform focused compression exams to rule out DVT. The technology guides users in real time, evaluates compression quality, and sends clips to the cloud for quick review by credentialed clinicians. It's a clear example of how AI is expanding access and reshaping the future of diagnostic imaging.
I do want to go more into the DVT exams because I know that the AI guidance product is really incredible because it allows non-ultrasound specialists to do this, right? And you kind of hinted to this in the beginning that this is the power that we can unlock really with AI is being able to allow someone who isn't really a specialist to conduct an exam. So can you just elaborate on how the guidance product works and then just maybe give us a scenario of what that could look like in a real world application?
Sure. So the guidance is essentially sonographic anatomy landmark based. There's some pre-guidance, so to speak. So let's say a nurse goes through a very focused training course on how to use the ultrasound transducer, the imaging device itself, which is usually going to be an Android or iOS phone. And the nurse is instructed where to put the transducer, and then the transducer can start analyzing imagery to see where you are on the leg. Do you need to move left, right, up, down, or proximal or distal? And then it identifies the correct location, basically the common femoral artery and vein, where you're going to start compressions. It can analyze the compression, especially in the education version, to tell you, is this adequate or not? And then you do several serial compressions. And the software can actually record that and analyze it on the education side, giving hints as to adequacy, suggesting, is there any evidence of a DVT after asking you? Because that's all about training. On the actual commercial version, that is meant to be used in hospital and elsewhere, that nurse is guided through a compression examination that the software helps analyze for adequacy. And then the video clips are uploaded to the cloud. And whoever is designated by the hospital is notified to review those clips. That could be the emergency physicians there, critical care, anybody who is properly credentialed. It may even be a radiology overread group if it's in the middle of the night. And this doesn't just have to be in the emergency department. It can be on the floors, ICU, clinics. And then whoever that designee is can review the ultrasound examinations that are provided to them, the clips. And they can, within about 3 to 5 minutes on average, they can determine if the DVT is adequately ruled out. If it is, then that patient can be sent home or scheduled for a comprehensive ultrasound examination in the future at a reasonable hour, whatever the hospital or clinic wants to do with their pathway, adapting their existing processes for the greatest efficiency.
As we continued Season 2, Episode 5 brought us a very different kind of insight, this time from a seasoned leader in vascular ultrasound. Denise Levy, a technologist with 50 years of experience, joined us to talk about operational excellence, patient care, and leadership from the front lines. Denise shares how long-term efficiency in imaging isn't just about speed, it's about smart planning. She emphasizes the importance of training staff on every protocol, educating schedulers on what can realistically be done and when, and respecting the time needed to perform a quality exam. As she puts it, you can't schedule what you can't do. With warmth and humor, she shares practical stories, like how a patient's burrito the night before can make it nearly impossible to get a good aorta image in the morning. Her message is clear. Efficiency starts with preparation, teamwork, and empowering every team member, not just relying on the go-to expert, to deliver quality care.
Can you provide examples of processes that you've implemented or improved over the years to enhance operational efficiency, especially that part of over the years, because you aren't just seeing this, of course, from the now, you have many years to tell us about.
um scheduling is so important to educate your schedulers. What exams are done in the morning, what are done in the afternoon, how do we prep the patient, how do we schedule the patient, what machine should they be on. um, Make sure your staff is all trained in that area. Make sure that your staff is all trained in every single exam, because when I was in some settings, people would say, "Oh, let Denise do it. She only does the proximal vertebral. None of us want to do it." Or, um, I do my carotids in 5 minutes. No, no, you can't. You can't do that. You have to spend some detail and get everything you need. So really, setting up success is having a good schedule and not creating a schedule that cannot be met. You have to look at how long does this exam take. You have to give that person the right amount of time to do the right job. You can't simply just limit something and go in it and do an artery at a spot check. You got to know the inflow. You got to know what's coming into that leg, what's distal to that leg. You got to know the size of the vessel. You've got to prepare the patient properly. If you have a patient that ate, burritos the night before, you're probably not going to see their aorta in the morning.
In Episode 8 of Season 2, Lachelle Jones, a seasoned sonographer with over 20 years of experience in high-risk pregnancy care, took us deep into the world of maternal-fetal medicine. She shared a critical, yet often overlooked aspect of safe and effective imaging, ultrasound physics. Lachelle explained how the ALARA principle, as low as reasonably achievable, guides every decision in fetal imaging, particularly when assessing the heart in the first trimester. With clarity and conviction, she emphasized that precision and safety go hand in hand. Her motto, back to the basics.
So, how do you balance those priorities in your practice? How do you approach the use of echo in those high risk pregnancies, especially from your perspective as someone who's been in it the whole time, as you say, all those 20 years? How do you approach that?
First and foremost, we all sonographers had to first do ultrasound physics. And so it goes back to what we've learned in our ultrasound physics courses, and that's ALARA. Every sonographer knows the acronym ALARA, and that's as low as reasonably achievable. And so when you go with that approach into especially looking at the heart, you think about turning on color in the first trimester, the benefit outweighs the risk. because briefly you're just looking at those heart structures with color to potentially diagnose congenital heart defects pretty early on. And so in that case, with that mindset, it's you're balancing the precision of diagnostic purposes as well as safety for the baby as well as mom as well too. So it's really important to remember those fundamental principles that we learned with the physics. That's something we learned prior to achieving your OB certification. And so you just have to remember your ultrasound physics principles when you do
Exactly. So it goes back to the basics.
back to the basics. That's one of my other mottos too. Back to the basics.
In episode 9, we had the privilege of speaking with Dr. Jordan Strom. Dr. Strom serves as Associate Professor of Medicine at Harvard Medical School and holds several esteemed positions at Beth Israel Deaconess Medical Center in Boston, including Director of the Echocardiography Laboratory and Director of Echocardiographic Research. In this next discussion, Dr. Strom addresses a critical and often overlooked issue: the gaps in training that are holding sonographers back. From disparities in IV and contrast training to broader systemic barriers, Dr. Strom outlines the educational challenges facing today's sonography workforce and the real-world consequences for patient care. He also highlights the efforts underway to close these gaps, including new credentialing initiatives and professional society support.
I'd love if you could tell the audience a little bit of the reasons behind the disparity you mentioned, because you mentioned how in one state, one patient may have a contrast agent used, but the chances in another state are a lot higher. So could you tell us some of the reasons you believe that those disparities are still there in terms of the adoption and use of some of these technologies?
Yeah, and I should say when we that disparity is still there when we account for things like age and clinical conditions and things like that that make somebody more likely or less likely to get contrast. We know even adjusting for those disparities, even adjusting for the rates of suboptimal image quality, we know that, for example, females get contrast at a lower rate than males do. Why that is, we've seen it is unclear. We've seen it in a number of different studies. It may have to do with sort of the less intense sort of treatment of females that we see across the board, across the medical spectrum when we look at a variety of different sort of diagnostics and disease states. Um, but I think the biggest barriers are really those that are procedural, that are workflow related. It's not hard to give a contrast agent, but you need to place an IV, and you need to be able to be trained on a contrast agent to give that contrast agent. And right now, um, less than 8% of sonographer institutions around the country offer any kind of IV training or certification. And you compare that to MRI or CT technologists, when they leave training, all get IV training. And so there's a real deficit. And so when it comes time to it, if you're doing an echo and you don't have IV training, but an outpatient walks in, they need contrast, and you have to call for an IV nurse to come place the IV, or you have to come, wait to have somebody place this, sometimes 30-40 minutes before they finally arrive. And then you have 20 minutes left in your exam to do everything else in the rest of the exam. So it in many times, it just is simply people forego the contrast. And why there's a difference across areas is a little unclear. And part of it may have to be with people trained. Historically, Minnesota and Mayo and the areas around it have been really sort of strong when it comes to contrast and using a lot of contrast. And so people trained there may tend to stay there and follow those practices. But it really is a little bit unclear. There are certain things, for example, around the IV and also the contrast training that could be improved. For example, we know that not only is IV training deficient in many sonographer schools, but contrast training overall is very deficient. And when you ask people in the field, why is it that you don't use contrast more? The most common reason is that people don't feel comfortable because they haven't been trained on this. And so if you have educators who aren't trained, they can't train the next generation. and next generation doesn't learn it, and it's a cycle. So we're trying to break that. The International Contrast Ultrasound Society, as well as AZ, has a number of different resources online that are free and available for people to review about how to build a contrast lab, how to understand the safety and efficacy of contrast, et cetera, et cetera. And those are really, powerful resources. We're also working with, actively working with Intelios, which is the organization that runs ARDMS, to be able to create a certification around IV training. Something that people can get after they leave school, so they don't necessarily have to have gotten it in school, but it's something that will be a notch in your cap that you can bring to your institution and say, I have had a national, an international training on IV certification. I have a certificate, is part of my overall credentials. And as we move as a field to, I think, acknowledge sonographers for all of the work that they do, that's not just scanning, but outside of scanning, things like leadership positions and otherwise, IV training is another sort of feather in your cap you can bring to institutions, and a lot of institutions are now, ours included, are now actually have some compensation payment that's associated with those kinds of softer skill sets.
Episode 10 features Dr. Amy Patel, a nationally recognized breast radiologist, educator, and healthcare advocate. She currently serves as chair of the ACR's Radiology Advocacy Network and RADPAC, and is a leading voice in shaping breast imaging policy at both the state and national levels. Dr. Patel emphasizes that advocacy isn't limited to policymakers or professional organizations. It's a responsibility every clinician can embrace. By engaging directly with their communities, educating patients, and making breast health information more accessible, physicians have the power to drive meaningful change well beyond the clinic walls.
Now, as someone who is deeply involved in advocacy and policy change, what role would you say that you see imaging professionals playing in advocating for patient education and access? How can they do more in their current role?
So, as breast radiologists or any of us who are delivering breast cancer care, whether we're a breast surgical oncologist or a breast oncologist, we are obviously very busy. And volumes are continuing to rise. And sometimes we think, gosh, do we have any extra hours in our clinical day to do anything else? But I am in the line of thought that I think it's imperative that we who deliver breast cancer care are educating patients. And it really is truly a grassroots approach, from going out into the community and speaking at events and talking about the importance of breast cancer, breast health, and not just in the month of October, but all year round. Whether you're going to, a community event that's being held at a community health center, whether you're speaking, you get a few moments speaking at a church on Sunday, any avenue that you can potentially have to go and to educate patients. I really feel that if you, as a physician who's delivering breast cancer care, feels comfortable in doing so, you need to be out there in the community and educating. Like people know me, there's nowhere I won't go. I will travel hours to rural parts in Northwest Missouri to talk to patients about the importance of breast cancer screening, frequency, getting risk assessed by age 25. What does that mean if you're above average risk? What does it mean if you have dense breasts? These things are important and they matter. And especially, things like breast density. And now with the new MQSA FDA mandate on notifying patients about their breast density, patients are still mystified by things like this. Like, what does that mean that I have dense breasts? And providers, primary care providers, OB-GYNs, some of them I have found need education on it and are wanting the education on it. So it's not just about us going out in the community, trying to find all avenues to educate patients, but we really need to be working together with our referrers, with our primary care, with OB-GYN, talking to them about the changes. What does this mean? Which modalities are superlative for women with dense breasts? How can these patients have access to that as well from a monetary insurance standpoint? All of these things truly matter. So we as particularly breast radiologists, we can play a very critical role in all of this and play just a very crucial role in the spectrum of breast cancer care and delivery.
In episode 11, we welcome back Megan Platfoot, an award-winning sonographer and educator, leading one of the most recognized programs in the country. Megan explains why collaboration in healthcare is essential, highlighting how sonographers, radiologists, lab techs, and even front desk staff all play interconnected roles. Megan also shares how sonographers' work depends on trust and clear communication with interpreting physicians, but also emphasizes the need for collaboration across all areas of healthcare. She talks about the importance of understanding other roles, like MRI techs or lab staff, and how breaking out of departmental silos can improve patient care.
I'd love to hear more on that, of how you've seen sonographers collaborate with physicians, with specialists in those real world settings, and what kind of effect you've seen it's having on patient outcomes.
Sure. So I think, first and foremost, when I think about this kind of collaboration, my brain first goes to interpreting physicians and sonographers. So whoever is interpreting your images, they want to be able to trust that what they get is exactly what the sonographer is seeing. Sonography is a little unique in the fact that at times we can send still images, at times we can send things like cine loops, like video clips, to be able to share what we're seeing, but they're not always getting the whole picture if the sonographer's not taking it. So it's necessary, it's vital that the sonographer knows the whole picture of things. They don't get tunnel vision when they're looking, and when they're scanning patients, that the way they can send over exactly what they're seeing to be able to adequately get that patient care and that diagnostics that they need. And the interpreting physician at the end of the day is trusting the sonographer, trusting the department, that their quality control and their initiatives in their department are where they should be. I do think at the same time, though, we traditionally think about sonographers and physicians, but even more, sonographers need to collaborate across the board with all of their healthcare professions. So it's not just sonographers and physicians that are going into patient care. We're thinking about the people that patients are seeing when they walk in. We're thinking about other kinds of diagnostics like X-ray, CT, MRI. We're thinking about a medical lab. We're thinking about all these people that are going into that form of patient care, that we need to look at the big picture, that patients are people. And while we may get them and we may see them for a certain amount of time, we have to understand more about each profession and what goes into it. And I said earlier that it is vital that sonographers embrace the education that they have, that we are not downgrading what we do.
That's it for our Season 2 recap. Thanks for listening. Season 3 is coming soon, so be sure to follow The Scoop on Ultrasound on your favorite podcast app, or subscribe on YouTube to be the first to know when new episodes drop. We can't wait to share what's next.